Now imagine yourself before the dawn of anesthesia, without the relief of pain, undertaking a surgical operation. Ouch. You've broken your leg or you've had your appendix rupture. Imagine the gruesome challenge that now awaits you. So this all began to change in 1846. Anesthesia, as we know it, first began when Dr. William T.J. Morton, a dentist, publicly demonstrated the use of ether as an anesthetic agent at Massachusetts General Hospital. And this was a groundbreaking moment on a worldwide scale because for the first time, surgery could be performed without excruciating pain. And Dr. Morton, who was providing the anesthesia, was also assisted by Dr. Haywood, who monitored multiple relevant vital signs using a finger on the pulse while carefully observing the patient's face and chest. And this was the first instance of a patient monitoring while using anesthesia. And from 1853 to 1862, approximately 68% of all major limb amputations for fractures at the Pennsylvania hospital took place on sedated patients, meaning that over 30% of patients did not receive anesthesia. And several case reports around the time continued to also display the hesitancy to adopt anesthesia into clinical practice. Now, several historical beliefs were also held at the time, both by the medical community as well as the public at large. One being that pain is an essential part of the healing process, and by removing it interfered with the body's natural response to healing. There were also beliefs that different social classes tolerated different levels of pain, such as that women and children required painkillers more often than did men, the rich and educated requiring it more often than did the poor, and so forth. And religious debates also ensued around this time period. For instance, Dr. William Henry Atkinson, an MD, as well as the first president of the American Dental Association, reportedly declared, "I think anesthesia is of the devil, and I cannot give my sanction to any satanic influence which deprives a man of the capacity to recognize the law. I wish there were no such thing as anesthesia. I do not think men should be prevented from passing through what God intended them to endure." And its early safety was also brought into question by several academics, as indicated and demonstrated by this quote from the Philadelphia Medical Examiner in 1847. Now, the American Civil War, however, was really a turning point in the adoption and acceptance of anesthesia. With over 80,000 documented cases, anesthetics were widely used on the battlefield. In those cases that documented which type of anesthetic were used, 76% used chloroform and 15% used ether, with the remaining using a combination of the two. However, the war also exposed serious risks, with over 5,000 Union soldiers dying secondary to surgical complications that may have been worsened by anesthesia. Now, despite these tragic losses, wartime experience helped physicians refine their anesthetic techniques and led to increased public and professional acceptance of anesthesia into medical practice. And a really good quote by Professor Syme in response to Dr. John Hall, who was an avid individual that was against anesthesia, Dr. John Hall, that being, Dr. Professor Syme stated that chloroform does not increase the danger of operations performed during a state of exhaustion. Chloroform proves useful directly in a proportion to the severity of the injury or disease and the degree of exhaustion or shock. So we can kind of see that around this time period, how different perspectives are beginning to change and go against the status quo. However, on the other hand, with the increased uptake of anesthesia into medical practice also came controversy as well as fatalities. The use of chloroform, infamous for inducing this sleep of death, initially lacked adequate safety protocols and monitoring standards, leading to significant mortality rates. In 1891, the death rate under chloroform was 1 in 3,258, while the death rate under ether was documented to be 1 in 14,987. And around this time, physicians were also disagreeing about how anesthetics produce their harmful effects. According to one theory, anesthetics interfered with the oxygen carrying functions of the blood and thus caused a loss of consciousness, circulatory disease, shock, and brain damage, and slow healing. And a larger number of physicians also felt that anesthetics produced their effects by directly suspending the functions of the nerves of the brain. And in an 1852 series of articles in the prestigious American Journal of Medical Sciences, Army Surgeon John B. Porter stated that by the inhalation of ether, even in the most cautious manner, in sufficient quantity to produce insensibility to pain, the blood is poisoned, the nervous influence and muscular contractility is destroyed or diminished, and the wound is put in an unfavorable state for recovery. Anesthetics poison the blood and depress the nervous system, and in consequence. And Dr. Foster Brewster Flagg also complained that deaths and less serious injuries resulting from the use of other agents, particularly chloroform, have been freely attributed to sulfuric ether. Chloroform was proved to possess the power to kill. Now, as anesthetics became more commonplace and medical attitudes towards anesthetic risks slowly began to adjust, physicians began advocating for standardized safety protocols. This included preoperative assessments, dosage guidelines, and the first efforts at intraoperative monitoring. However, these early efforts and measures were still primitive. Patient monitoring started out as a manually performed, intermittent, and qualitative assessment of the patient's general well-being in the operating room. Non-invasive blood pressure monitoring was also commonplace in the early 20th century, pioneered by the one and only Nikolai Kordakoff, of whom you may be familiar by the term Kordakoff sounds. And he showed that by placing a stethoscope over the brachial artery at the cubital fossa, one could determine the systolic and diastolic blood pressures of the patient. And manual and non-invasive blood pressure measurements also remained the mainstay until the 1970s when oscillometric-based automated non-invasive blood pressure monitors were introduced. And the left image of this slide demonstrates one of the first documented images utilizing the Keeler polygraph, a method for measuring abdominal and thoracic respiration. Now, by the early to mid 20th century, the field of anesthesiology emerged as a distinct clinical specialty with the introduction of devices such as the ECG and continuous blood pressure monitoring. We were now able to track vital signs more effectively, reducing mortality rates, enabling higher risk, and more complex surgical procedures and surgeries as a whole. And in its evolution, patient monitoring development responded to this clinical need. For example, in the 1980s, there was a groundbreaking study that showed that anesthesia adverse events could be prevented by improving monitoring, especially respiratory monitoring. The O2 pulse oximeter, a device that today can be found anywhere from the OR to family medicine clinics, was developed in 1974, somewhat by accident, in fact, by a Japanese bioengineer, Takuko Aogi. And the 1990s then saw the integration of displays in computers, while today devices have become less invasive, more accurate, and more continuous. And currently, we estimate mortality due to anesthesia in healthy patients to be 1 in 250,000 to 1 in 400,000, perhaps as much as 10 times lower since the early 1980s, and a significant improvement from the estimated 1 in 3,256 mortality rate in the mid-19th century. So, from battlefield surgeries to modern AI-driven monitoring, anesthesia has truly undergone an extraordinary transformation. And while anesthesia is now safer than ever, the field continues to evolve. Artificial intelligence and machine learning are being integrated into anesthetic monitoring. These technologies can analyze vast amounts of patient data in real time, potentially predicting and preventing complications before they even occur. However, ethical concerns still remain. How much should we rely on automation? And where do we draw the line between machine assistance and human judgment? Where does the intersection between patient safety and patient privacy lie? These are all questions at the end of the day that need to be addressed with high scrutiny as we look forward into the future. History has shown us that the risks associated with early anesthesia forced the medical community to innovate and improve patient safety. Now, by understanding this history, we can better appreciate the safety measures that we now take for granted and continue striving for even greater advancements in patient care. So that concludes my presentation. I would like to extend my sincerest gratitudes to my preceptors, Dr. Devine and Dr. Sun, for their guidance and support throughout this project. So thank you all for your time in listening to this presentation, and I'm wishing you a wonderful day ahead.